Janet. So welcome to everybody. For those who don't know me, I'm Bolesław Posmik, chair of the Tees Valley CCG and a GP working in Hartlepool and in Darlington. Now we've got public members. We're 3 notified beforehand. So we'll go around. I'll ask people to individually introduce themselves so that the public members can know who we are and what our roles are. But until I ask you to say who you are, if you could stay on mute for the time being, and then during the meeting, if you'd raise a hand, either physically or using the chat function, reaction function rather, in Zoom. And then I'll call you to speak if necessary. Okay, so going around people on my screen to introduce themselves. TVCCG CorpGov. You're on mute, CorpGov.
Sorry about that. My name's Jane Smales. I'm the corporate support for the committee.
Okay, Karen Hawkins.
Good afternoon, I'm Karen Hawkins. I'm the Director of Commissioning for Primary and Community Care in the CCG.
Jackie Keane.
Hello, I'm Jackie Keane. I'm the Head of Governance for the CCG. Dog in the background.
Janet Walker.
Hi, I'm Janet Walker. I'm a GP and I'm Medical Director for CCG.
Julie Bailey.
Hi, Julie Bailey, Partnership and Health and Inequalities Manager, and I'm here to present 2 items to the governing body today.
Okay, Caroline Gisham.
Good afternoon, I'm Caroline Gitcham and I'm a lay member on the governing body.
Okay, Nick Marco.
Hi, I'm one of the members of the public joining today. I'm the local democracy reporter based at the Hartlepool Mail.
Hi, David Gallagher.
Afternoon, everybody. I'm Dave Gallagher. I'm the Chief Officer at the CCG.
Michelle Thompson.
Hi, I'm Michelle Thompson. I'm the CCG's lay member for patient and public involvement.
Okay, James Neverson.
Good afternoon. I'm a GP from Darlington and a non-executive GP on the governing body.
Craig Blair.
Hi, I'm Craig Blair, Director of Commissioning at the CCG.
Okay, David Emerton.
Hello, I'm David Emerson. I'm a secondary care doctor on the governing body of the CCG. That's a non-executive role.
Jean Golightly.
Good afternoon, everybody. I'm Jean Golightly, Director of Nursing and Quality for the CCG. Thank you.
Okay, Joe Bushnell.
Good afternoon, everybody. I'm a pharmacist based in GP practice, and I'm a non-executive healthcare professional on the governing body.
Okay, Dr. Hollingsworth.
Hi, I'm Jess Hollingsworth. I'm a GP in the Middlesbrough area and also one of the non-executive board members.
Okay, Karen Dales.
I am Karen Dales. I'm a lay member and audit committee chair.
Okay, Mark Adams.
Hello, I'm Mark Adams. I'm Director of Public Health for Middlesbrough and Wrekin and Cleveland.
Okay, Mark.
Hi, it's Mark Pickering, Chief Finance Officer, and apologies, my camera stopped working in the last 5 minutes, so apologies.
Right, okay, that explains it, right. Andy.
Hi everyone, I'm Andy Mackay. I'm the independent member and chair of the Quality Committee.
Okay, Mark Briley.
I am Mike Briley.
Sorry. Sorry.
I've been called worse. Director Lead for Mental Health and Learning Disability in the CCG.
Yeah, sorry, you threw me because your icon just popped over the screen somewhere different. Okay, Alistair Johnson.
Hi, I'm Alistair Johnson. I'm a GP in Stockton and one of the non-exec members on the governing committee.
Alex Sinclair.
Hi, Alex Sinclair, Director of Commissioning for Children and Young People in the CCG, and apologies, my camera's not working despite trying to switch it on and off.
Yeah, it's okay. Andy. Andy Mackay. Well, he's a lay member on the CCG. Okay, obviously having problems, and there's Janet Walker who's having, some intermittent problems. Okay, so we'll bear that in mind. So this is a meeting in public, hence it's on Zoom, and also it's being recorded for later being available for the public on the CCG website. Now, having started the meeting, because of the fact that this meeting's today rather than yesterday, I think it would be appropriate for us to take time to have a minute's silence to remember the 126,000 people who have died of COVID since the COVID lockdown 1 year and 1 day ago. So if we just take a minute to consider those people. Thank you. Okay, thank you very much. So we'll move on with the rest of the business of the meeting, but we basically need to remember that we're here to make sure that we're providing the right services for all of the population of the Tees Valley, but sadly it's been very difficult in the last year. Right, okay, so I've got apologies from Hassan Tahir for this meeting. Have we got any other apologies at all?
Yes, we've received apologies from Penny Spring and Craig Blundred, Directors of Public Health for Stockton and Hartlepool.
Okay, thank you very much. And have we had any other business notified that's not in the agenda that we've had sent out? No. Okay, so there's a declaration of interests attached to the papers. Has anybody got anything else to add to the declarations of interest, so particularly in matters arising on this particular agenda? There's no's all around. Okay, thank you very much. So there was one in relation to the patient and public involvement update. The lay member Michelle is a chief exec of Health Watch Darlington, so we note that as well. So you can remain in the meeting and take part in the business, but we will note the declaration, Michelle. Okay, so over to the unconfirmed minutes of the previous meeting. So if we go through those for accuracy, and then we'll do actions afterwards. So this is page 8 of the pack. Page 9, page 10, page 11, page 12, page 13, page 14, page 15, page 16, page 17, page 18, page 19, page 20, page 21, and page 22, and lastly, page 23. Okay, so everybody happy with those as a true and accurate record? Yeah, nods all round. We had 2 actions Following that, and they've both been completed for Dr. Johnson, various matters, so you're happy with those. They're marked off as having been done. Okie doke. So come very briefly to the Chair's report. I won't go through it in detail. We've noted that we're a year on after lockdown. The major thing to note, I think, now is the fact that we've now well over 20 million first doses of COVID vaccine given. So formally to put on record the governing body's recognition and thanks for all of the huge amount of work that everybody's been carrying out to make that happen. And noting the fact that we're now beginning the process of second doses. And okay, we're aware of the issues that are in the public domain in relation to all the concerns in various parts of the world about vaccine and vaccine supplies, but still everybody who's involved in the vaccine process is doing a sterling job. And particularly you've got to highlight the fact that a lot of this has been taken up by our primary care colleagues, but now that there's also increasing provision in mass vaccination centres and pharmacies as well to make the process, increase the capacity of the process, because effectively we're now delivering almost twice as much as before because we're doing first doses and second doses. The other thing to note is the integrating care process is now beginning to roll its way, heading for an act of parliament, which will eventually result in the fact that CCGs cease their present operational form in March 2022, and the large part of the work carried out by the CCGs will move over to integrated care systems from April 2022. So we're particularly noting the fact that we're working with our member practices to see how they're wanting to be engaged in the system in the future, and also particularly highlighting the fact that the national information provided is for our CCG staff is that they are all, apart from those of us who are on the governing body, as governing body members, everybody has got a role in the future system and has got guaranteed employment, which I think is important to provide reassurance to our staff members. Okay, so that's it on my report. Any questions before I move on to Dave's AO's report? No? Okay, so over to you, Dave.
Yeah, thank you, Paul, and I'll take your lead. I'm not going to go through all of the information that's there. People have had a chance to read it. I'll just reiterate our collective thanks, I think, for everybody that's worked so hard over the last 12 years, 12 months, feels like 12 years, on COVID, particularly the effort for vaccination, but certainly looking forward to the future and recovery of services that we'll be talking about a little bit later in the agenda, but also as an organisation recovering, actually gradually getting people back into the office in a safe working environment that we'll pick up in future months. You've mentioned the integrated care systems. I'll talk about that further on in the agenda. Probably just a couple of things to mention is one, the staff survey that's alluded to there. We've got the information back from our staff survey. We've shared it with staff. We're going through a bit of a process to do the so what in terms of the service. This is what we'll do with it, and we'll bring that back to governing body once it's had a bit more work to do. And last thing to mention, something that didn't go into the report because I didn't know about it at the time. As an organisation, the CCG has been recognised with the Bronze Award for the military employers, which is a good achievement. With a little bit more work, we can probably get that to silver level. It's not about badges on the border, it's actually about the commitment to the armed forces, veterans and their families. So I think that's a really good step to take, and hopefully we can get that to a higher level as quickly as we can. So other than that, I was happy to take any questions on anything in the report.
Apologies, I've done it. I'm now unmuted. Anybody, any questions on Dave's report? Okay, thank you very much, Dave. So moving on, hopefully, Janet, you'll be able to sort of get the technology okay for your report. The locality update.
Hopefully so, and it will hopefully be suitably swift as well. Understandably, general practice continues to work very differently. We are still operating under total triage, although we are seeing patients face to face. It's making sure that, yes, we do that in a safe way so that patients and our staff are protected. So we are continuing to do that. Our clinical leads who are working with the CCG are still, as required by NHS England, dedicated to working in practice to make sure that they support the practice and delivery of COVID vaccination. But I am still having contact with clinical leads through email dialogue, and also having contact with the executive GPs who work for the CCG, so able to keep a finger on the pulse, not only for my own working practice, but also, what others working with us have told us. So yes, understandably, everyone is continuing to work exceptionally hard, delivering services to patients, making sure that we can address and deal with the backlog that has happened through a variety of elements and waves of the COVID pandemic, but also alongside the sterling work that continues to deliver the COVID vaccination programme. So, and it is fair to say that, yes, I think many of the practitioners would agree, Dave, it does feel like it's 12 years rather than 12 months that we've been continuing to work through this, in the same way that all of us out there, as patients and individual residents, feel the same way. Sterling work is ongoing with regard to the COVID vaccination campaign, and yes, the government has outlined the targets with regard to everybody wanting to be vaccinated by the end of July or offer their first vaccination by the end of July, which are continually stretching targets, in addition to managing with everything else that we would wish to achieve for our population across the Tees Valley. I think it is worth stressing at this point the need for us to have some awareness about health inequalities, and whilst we are all focusing on how we are having to do things differently and deliver on a different basis, it is especially important across the Tees Valley that we don't lose sight of our need for a focus on not widening any of the health gaps and our inequalities, and certainly from a COVID vaccination point of view, as we are managing to have great success with reaching many, many people with the vaccination, that we can now have a greater focus on directing it towards those populations that are harder for us to reach historically with other vaccination campaigns, and indeed making sure that, yes, we do what we can to increase vaccine confidence amongst all of our population and remove any barriers to people being able to access the vaccine. So those programs will continue, and yes, that there are certainly things that our practitioners are wanting us to focus on, as well as making sure that we can deliver all the services that we need to deliver, but be mindful of the fact that we are practicing in a different way, and making sure that we support our patients to be aware of how we are practicing differently, to make sure that they feel reassured to come forward as and when they need to do so. Though we haven't had any formal engagement with practices at this stage, understandably, because we are just now emerging from the latest wave of the pandemic, it is time for us to be regrouping. And when I have clinical leads returning to work in the CCG, we'll be able to look at our next formal engagement with the practices on a Tees Valley basis.
Okay, thank you, Janet. Any questions from anybody? Has there been anything reported, Janet, by way of the level of communication that people want in relation to COVID, and has that impacted on practices' ability to deliver their normal day-to-day care?
Understandably, there's a lot of variety of anxieties amongst our patient population with regard to elements regarding COVID. But firstly, from a COVID disease point of view, we continue to provide services that meet the needs of those patients who are suspected as having COVID or have known COVID, and are seeing them in their continued hot clinic provision, as well as the services that they will be accessed via their ordinary GP surgery, the COVID virtual ward, which is a service run by the hospitals, and our COVID oximetry at home continues to provide monitoring services to those patients with COVID. Understandably, COVID vaccination and issues and questions with regard to COVID vaccination continues to be an area of significant pressure, and understandably everybody out there wants to know when they are going to be able to access their own COVID vaccination. And we would encourage patients to be aware that, yes, the NHS will contact you when it is your turn to come forward for vaccination. Yes, we would very much want you to be able to respond to that invite when you get it. We will get to everybody in turn. I appreciate the frustration, but it is really important that, especially with practices working so differently and relying upon remote means of consultation, that we encourage patients to not telephone their practice with questions about the vaccination appointments that may prevent other patients being able to get through with urgent healthcare needs. And it's so important that we still are able to meet those needs for them.
Yeah.
There are frequently asked questions available on the website. We are working very closely through social media channels as well to try and keep the public as informed about COVID vaccination and the twists and turns of the programme as it goes on.
Yeah. Okay. Thank you very much. Anybody else for questions before I move on? No, that's fine. Okay. Thank you very much, Janet. And now over to you, James, for council members updates. So that's member practices. James, you're on mute.
No, I'm not. I'm speaking, I hope. Here we go. Yeah, so I chaired a meeting on the 7th of January for our council members. This is the meeting with representatives from all of the member practices in the Tees Valley CCG. And it was about the new paper and the formation of ICS. The level of importance that member practices put to it was highlighted by the fact, I think it's the biggest Zoom meeting I've been in. I think there were probably over 100 people on it. It was unbelievable, but I think it shows the commitment and the concern that member practices have with the changes that.
Oh, yeah.
I'm back on, I think. I don't know what's happening to my computer. So our executive team were able to go through the major areas in the paper, and the representatives kind of came up with a few broad areas of concerns, worries, or wishes for to put forward to the planning for the ICS. So one of those was a concern about how primary care could maybe influence decisions in the future in such a large organisation. So that was, one way we needed to get that put into the plan so that primary care could still have that influence, because we feel that we've got a lot to give. Practices really benefited and appreciated lots of support that we got from our local CCGs, who we feel know the practices well and know what we need. And there was a concern that maybe that support could be lost in the new organisation. Some members, I think, who've put in a lot of work over the time in getting our Tees Valley CCG to where it is now over the last few years, were, felt a bit sad that the changes were coming in so quickly again after all that work. But there was a hope that in the future the planned changes would benefit our population as a whole if these things could be brought into play.
Okay. Thank you, James. Any questions on that report? I know there's some bits that Dave might want to pick up, but he's got a section on the ICS across England later on. So rather than doing it now, Dave, if there's anything that you want to pick up in relation to what James has just mentioned, if you pick it up during that section. But anybody else got any questions or comments? No, thank you very much. Yeah, massive. I was on that meeting, James. I think that was probably the biggest one I've ever been involved in as well. Yeah. Okay, thank you very much. Now moving on to patient experience and engagement. Over to you, Michelle.
Okay, I won't go through every single bit of the report because it's quite long, but if we start with the external meetings that I've been attending, one of them was the Integrated Care System Partnership event, and I've listed down the key areas of discussion there. There was a lot of external organisations that were wanting to ask questions. unfortunately, some were quite frustrated because it was just at that time where we're not really sure what it's going to look like. But I'm sure moving forward, there will be questions and answers given later on. The digital shared care records, I'm really interested in this because of the Great North Care Record across the region. This was at a national level, and just how shared care is actually how that's explained to patients. A lot of patients, well, many, if not all patients, think that their records are shared anyway, and it, you know, not realizing the implications that there is with the different computer systems. So it's just making sure that, you know, in the future, people do understand what is actually happening to their data. The next thing that I found fascinating was artificial intelligence. I always used to think that this was, you know, robots and computers going mad and taking over the world, but actually it's really, really interesting. And the National COVID-19 Chest Imaging Database was given as an example of how artificial intelligence can be used and to enable the best care for patients. So I'll continue to go to those events. The Northern CCG Joint Committee, in the public part of the session, it was there isn't much to report. It was just accepting the minutes on that one. And then the NHS engagement session. This is at a national level again, but this there's a lot of people that are sat around the table from national organisations for patient voices and for the voluntary and community sector. And one thing that NHSX were sharing was the digital playbooks, which covered cardiology, respiratory, MSK, dermatology and eye care. They're a really good resource that I found for members of the public as well as for clinicians, and they just give examples of how different pathways are highlighted and how they can partner with digitally supported care, including acute patients. So there's a whole raft of information there that was really, really interesting for the patient voice organisations that were sat around the table. The Darlington Community Council and Hartlepool and Stockton Health Ambassadors, as well as a new South Tees patient group, will be discussed by Julie in the next paper. But it's just to say that I'm really pleased that going into this next financial year that we're going to be able to look at these three groups to work with the CCG to have a more consistent approach, because I think going forward with the ICS, it is really important that we do have that patient voice from the southern region. So I'll be really pleased to see how that goes with Julie and the team. For the local health watches, you can see just how busy they are. I'm not going to go through the themes, but there's a wealth of information there that gives you a flavour of what the topics that they're looking at, the complements, the issues, the barriers to services across the Tees Valley area. So all 5 health watches are working really hard just to ensure that patients are getting the right information at the right time, and especially about COVID and especially about the vaccines. You know, considering that we've got the mass vaccination centres as well, and there have been problems with people with sensory impairments actually getting the right information at the right time. So again, it's just, you know, if there's anything specifically that you can see throughout those Health Watch updates, you can get in touch with the individual Health Watches, and I'm sure that they'll be able to give you more information on those things. And then lastly, there's just the Health Watch England update. So again, this is at a national level, and it's just to give you a flavour of what Health Watch England are gathering across England from the 152 Health Watches. And that's it. So if anyone's got any questions or comments, I can take those now. No, there we go. Thank you.
Yeah. Michelle, sorry, I was waiting for a pause to bring us in. You might be on mute still. It was just to offer some reassurance to the governing body members in relation to a number of the areas that were picked up from a Health Watch perspective in the reports. From a South Tees perspective, we had linked in with the South Tees Health Watch representatives through the Primary Care Committee, because it also raised some concerns in relation to access, and particularly for our deaf community. So a member of our primary care team attended a public meeting with Health Watch to address some of the concerns that were raised, to discuss some of the new ways of accessing GP services, and also to create a link back to NHS England in relation to interpreting services to make sure that that was addressed. And that was from a South East perspective. There was also an area that was raised in terms of a query through Health Watch Hartlepool in relation to the individual with diabetes and the concerns in relation to accessing the diabetic retinal screening service. So we have picked that up directly with North Tees Foundation Trust, as they're the providers of the diabetic retinal screening service, although that service is commissioned by NHS England. So we've also made them aware of that, but it is sitting now with North Tees to make sure that they're able to pick that up and address any concerns raised through that. So it was just to offer some reassurance to members that although there have been some issues that picked up, that we have addressed where those areas that we can, and we find the report really helpful to give us that soft intelligence where we can look to try and improve services for our local communities. So thank you.
No, that's really good to know, Karen. Thank you.
Thanks, Karen. That was a useful prompt. I've got Janet and then Alistair.
Yeah, just to add what Karen said, actually from a COVID vaccination point of view, on the 9th of March, there were some very useful updates to the British Sign Language videos that are there to support our members of the deaf community who are able to access information by signing, that give a lot of useful information about the vaccine, what to expect, special guidance with regard to if you're pregnant or if you're breastfeeding, and access it via BSL communication. And they're really, really useful, and they're all available on the gov.uk website. And from a learning disability point of view, need to stress that yes, any member of our population who has a registered learning disability is eligible for priority COVID vaccination in cohort 6. So just to clarify that definitely is the case across all of the Tees Valley.
Great, thanks, Janet.
Thanks, Janet, and then Alistair.
Well, hi, thanks for that, Michelle, and also Karen, about my sort of parochial interest in the deaf community. I'm a BSL user myself. And so whilst I can engage in video calls with patients, and that works pretty well, I'm always conscious that it's quite difficult for them to actually book the appointments in with me. So I think on a practice level, I think we can do a lot more to help not just the BSL users, but also the more elderly population with acquired deafness who really do struggle. And I think they're a poorly served part of our community. So thanks for raising that awareness.
Sorry, just for clarity, BSL presumably is British Sign Language?
Yeah. Yeah.
Yeah, sorry. Okay, anybody else, any other questions or comments on Michelle's bit? No, okay, now over to Julie, is that right?
Yeah, thanks, Chair. So just colleagues have read the report. I'll just give a flavour of some of the key messages in there, just to supplement the overview Michelle's given. You'll see the first item is the results of the patient and community engagement indicator. They're not for our CCG. The assessment was done prior to Tees Valley CCG being established, but I think there is much we can learn, and some of the ways of working have come with us into the new organisation. So there's a clear steer there that we could look at strengthening potentially, or ensuring that the Tees Valley CCG work around annual reports, equality and inequalities, and feeding back on responses to issues or what we've heard from patients and public, that we're really clear where we do that. And I think we've got some examples from what we've just talked about of how we are responding to the feedback we get from patients. So that's something for us to do going forward, and to help us with our assessment as Tees Valley CCG. Throughout the pandemic, we have continued to engage with local people. So we just need to ensure that we're feeding that back, and that's clear on our website for patients and the public to see, particularly how it's informing our work. As Michelle mentioned, the community health ambassadors have continued to meet. The Darlington Community Health Council have continued to share information on our behalf. to ensure it gets to local people, and we are about to review bids for providing a similar service in the South Tees area as well. And that's an area that NHS England were keen to work with us on in terms of a response to the community indicator feedback. There's quite a lot in the report on public messages. We've not just kind of promoted news around COVID, there's stuff in there around the winter supplement and the online stuff, as well as the paper-based messages that we gave. With regards to responding to Health Watch reports, it's been business as usual. Health Watch organisations have been busy, and we've been using the outcomes of their reports to inform our work. New in this report, there's some information around equality and diversity, and we've agreed to talk to local people about our equality objectives. We were holding off because we were waiting for the new NHS England equality delivery system. That's been delayed, so actually we've taken the decision that we just want to go ahead and talk to local people about what's important around equality and diversity and what are some of the things that we should be working on as a CCG. So that's the key area of work for us going forward. And I'm happy to take any questions on the rest.
Thank you, Julie. Any questions, observations? No? Okay, thank you very much. Nice and comprehensive update. Thank you very much. So those are noted. Both the reports are noted, and particularly I'll just go slightly back to Michelle's. That there's a very nice positive COVID thank you story from a family there, which is so very, very nice to note. There's a level of care they received. Okay, thank you very much. Now back to you, Julie, again in relation to collective promise to BAME colleagues and communities.
Thank you. So just by way of background for colleagues, this originated from a commitment across the North East and Yorkshire by healthcare leaders to better support people from ethnically diverse communities, and they agreed to develop this promise to staff and local people, driven in part by what we've learned throughout the pandemic about inequalities. They're inviting all organisations to join them in signing up to this commitment, but more importantly, it's about taking forward the actions to ensure it's more than just a promise. Much of the actions set out, I think, dovetails with our existing action plans, you know, the work we're doing around the workforce race equality standard, the people plan. Perhaps there's some additional action for us to think about as a governing body, which we could incorporate into the development programme around senior leadership and awareness of equality and diversity and inclusion, but we've already started some of that work. So in terms of action, I don't think there's a lot that's new for us to consider, in my opinion, in signing up. We are listening to feedback, and we're hearing that BAME might not be the most appropriate descriptor to use, although this is the title of this promise that's been developed across the region. So we'll reflect on that as we progress this work and the work within our people plan and equality work programmes, but I don't think it should stop us from signing up to this if we're comfortable in doing so. And that's my ask today, really, of the governing body. Are we happy to sign up to this promise for Tees Valley CCG, and most importantly, take forward some of the work in there? As I said, I don't think it's anything new, but I'm not saying we've got this absolutely all sewn up. There's definitely work for us to do. I just think the ask isn't anything in addition to what we've already considered as a governing body.
Okay, and it's not just something that we sort of talk, we walk the walk as far as we possibly can prior to even signing up to this. So are colleagues happy to sign up for this, myself, Dave, and...
Yes.
Yeah?
Yes.
Yeah. Okay. Okay, nods around the table. So that's noted and accepted, and we'll sign up to that. Thank you very much, Julie. And now over to Mark for our financial plans for the year 21 to 22.
Okay, thank you, Chair. So firstly, apologies, you can't see me. My camera doesn't want to play today for some reason. However, what I'll ask Jane to do is just share some slides on the screen. Thank you, Jane. The format of this will be a couple of slides from myself, and then I'll hand over to Craig to provide a bit of an update on planning, and then there'll be an opportunity for questions at the end, if that's all right.
Let me just get this to... Why will this not work? It won't work.
It's okay, if you just click on slide 2, will that
yeah,
pop slide 2
sorry,
up?
I'm just struggling a little bit with it.
So yeah, that's going to work. Great.
Excellent. Thank you, Jane. So in terms of financial planning this year, as you know, we're in a temporary financial regime as we approach the end of the current financial year. In terms of planning for next year, many of the timescales have been impacted by the pandemic. So lots of delays in terms of usual planning timescales. And as a result, we now know that the current financial regime has been extended into the first quarter of 21-22. That includes the block contract arrangements that we have with our main NHS providers. As a result of that and some of those delays, we don't yet have the financial allocations for CCGs, of which, of course, Tees Valley is one. And in the absence of that financial allocation, it's difficult for us to capture not only the expenditure plans, but also some of the income assumptions against that. To mitigate against that, we're extending the majority of our existing commissioned services in line with national guidance, and that'll extend into Q1, and that enables continuity of service and takes away any of that risk. There is an expectation that there will be a national settlement that covers the first 6 months of 21-22, and we're just awaiting clarification of that. So we know it's for the first quarter, we just don't quite know what the second quarter looks like yet. Next slide, please, Jane. So traditionally, we would be considering an annual budget paper at this meeting, the March meeting of the governing body. But because we don't have that guidance and those financial allocations, that work hasn't been possible to complete as yet. The timescale for allocations is before the end of March. So bearing in mind where we are now, we're expecting to receive some information, if not in the next couple of days, then certainly next week. So I'm aware that there are some plans being considered at a national level during the course of this week. That'll enable us then to work on some of those financial plans and draw those together in accordance with national timescales that will take us through into April and May. That fits with the comments on the previous slide around having the temporary financial regime into Q1. Once we have that information, we'll share those plans with governing body as soon as we can. But I'm sure you'll appreciate that at the current time, the best we have is the extension of the current financial regime into Q1. Next slide, please, Jane. So I'll just hand you over to, that's okay. Yep, I'll hand you over to Craig at this point to pick up planning generally.
Thanks, Mark. Cheers for that. Okay, thanks, Jane. So I thought it'd be useful just to start with a slide that gives an overview of where we are in terms of what we would normally term as the planning round. What you've got in front of you there is, on the left-hand side, the 2019 baseline year, if you like, an ordinary planning round. In the centre is 2020 and what happened during COVID, what has happened during COVID, and then 2021 on the right-hand side, what we expect to happen this year. So you can see that usually we'd spend the first 3 or 4 months of the year as an organisation working to develop our plans for the coming year in response to the planning guidance, the operational planning guidance that would usually be published on Christmas Eve. Organisations would spend time during January understanding and assimilating that and then provide their responses. Normally I'd be sat here running the governing body through our proposals, aspirations for the coming year and how we're going to go about delivering those. As we've seen through the pandemic, that's not been possible. So NHS England has not been able to publish a set of operational planning guidance in the usual timeframes. And during 2020, we actually received 4 phased COVID response letters, which set out some of the key actions that we needed to take forward to help the health system respond to the pandemic. As we move forward in 2021, what we've looked to do is review our plans from 2019. So the long-term plan response that we'd originally pulled together in January of 2020, and look to update those in a reflection of the progress that we had or hadn't been able to make over the last 12 months. So on the right-hand side column there, you can see Tees Valley CCG's commenced a programme of work to refresh our ICP, Integrated Care Partnership level OGIMs. Those OGIMs are outputs, goals, initiatives, measures, sorry, pause. And they are in essence plans on a page that set out the things that we were aiming to do last year. We've looked at those, refreshed them, and update them with whatever progress we were or weren't able to make ready for the year ahead. Now, clearly we've done that ahead of any further guidance being published by NHS England around what the national expectations and requirements are. So we found out earlier this week that NHS England expect to publish the operational planning guidance following an NHS England board meeting tomorrow. So hopefully very shortly we'll have some clear understanding and expectations around what we need to deliver this coming year. Jane, if you're able to move forward for me. Just a little bit of overview in terms of the planning guidance itself. So the long-term plan was published in January 2019. We've spent time trying to understand what the requirements of that were, what we were going to deliver, and then that was distracted by COVID. Set out on there the 4 COVID phase letters that we've received over the course of the last 12 months, which helped us through the initial first phase of the pandemic, then the recovery from that first phase towards the end of the summer period, which we then went back into another phase of escalation during Christmas and the early part of 2021. We are expecting the guidance that's going to be published later this week or early next week to focus on the first 2 quarters of the year. So there'll probably be 2 bits of planning guidance for 21-22, first 6 months and then second 6 months. And if we can move forward, Jane, just to give you a bit of a feel for the things that we have been dealing with in terms of our plans, and then moving forward what we expect to see. So the priorities through the first 4 phase letters included how we responded to Brexit whilst dealing with the pandemic, making sure that we follow good COVID related practice, so social distancing, supporting discharges from hospital, designated settings and things like that. Responding to our COVID demands, how do we make sure that we've got enough capacity in hospitals to manage those patients coming in, the vaccination programme, which we've touched on already, maintaining some of our essential services such as cancer services, etc., and vital surgeries, prepared for the winter, because obviously whilst COVID was here, we still had a winter and there was a lot of work required to make sure that we were able to manage winter demands on top of COVID. And also thinking about how do we keep our workforce safe, healthy and well whilst they dealt with the pandemic themselves, and continue to address any health inequalities. So there's some of the things that have come out this year that we've been working with. Jane, if we could click forward in terms of expectations for the coming year from April onwards. We haven't had any specific guidance yet. As I've said, that's due to come out shortly. But some of the noises that we've picked up and some of the heads up intelligence suggests that obviously we'll need to continue to think about managing the ongoing pandemic. So COVID hasn't gone away. That'll need to be part of our business as usual. So COVID specific service provision around how do we respond in a hospital setting, what are the primary care needs, etc. How do we keep that going? The vaccination program, continuing to roll out to additional cohorts and any necessary booster program. Supporting the whole system to recover from COVID. So primary focus around getting services back up and running, making sure that we're delivering the elective programs. We've got a big backlog of elective cases that we need to work through. What lessons can we learn from the pandemic? So things like transforming our outpatients programs. Can we do more non-face-to-face, so reduce the need for people to physically attend hospitals, etc. Continuing to deliver against the constitutional standards, because there's been a real pause on some of the work around patients accessing routine care, diagnostics, etc. How do we pick some of that back up? And then addressing the increasing demands for mental health services, including maintaining the mental health investment standard. Obviously, we've got the NHS People Plan, which helps us identify some of the key actions we need to take in terms of looking after our staff, our people, so that we can continue to deliver services in the best possible way. Expanding and increasing the use of primary care and focusing on population health management so that we can reduce the number of people who require hospital-based interventions. Improving community and urgent care and emergency care services. So again, trying to reduce demand on ED, emergency departments, A&E, and managing patients through other dispositions and services. And then obviously reprioritising the requirements of the long-term plan so that we can make sure that those things that are still relevant, we do pick up and follow through in year, that our responses are tailored to local needs, local service provision, and the local inequalities that we're trying to address. Jane, if we could just click forward. That's the end of the presentation. Pause. Like I say, we are expected further guidance and information tomorrow. I'm not sure whether Dave wanted to add anything in terms of planning following a meeting he was at yesterday.
Over to you, Dave.
I think you've said it all, Craig. There's some bits and pieces that we'll get more detail on tomorrow once it's been through the NHS England board. I suppose the other bit that links in with an item later on the agenda, that will be an annex to the plan, or the planning guidance rather, that will ask for developing detail from ICSs on how they plan to move forward. But hopefully we'll have lots more detail tomorrow from all of that.
Okay, slightly sort of bad timing for our governing body meeting in relation to the planning timing, but you know, it is what it is. David, you got your hand up?
Thank you for that presentation. I was just wondering if there's any national input from research and innovation. I mean, we touched on how things are certainly done differently in quite a lot of areas, as to whether there's anything more about any more modern treatments which could replace the needs for certain procedures and so on, and how that fits into the planning process.
Would you like me to try and respond to that, Pos?
Yes, please. Yeah, Craig.
So I suppose when we get the planning guidance, there's reference to development, whether they're technological or pathway improvements, and I know that there's work ongoing within across the northeast and Cumbria ICS around some digital innovations for particular pathways or treatments. So at the moment, Newcastle are looking to do some work around breast radiology and tapping into some innovations around digital technologies to not only diagnose breast cancers, but also to support with the undertaking of scans. And that's a pilot piece of work that would then inform a collective position and response to some of the pathway challenges that we've got. In terms of a formal approach, I think that would predominantly come through either the planning guidance or the work that we do with some of the more bespoke groups, David, across the region, to look at what are the opportunities for us and how do we tap into those. The CCGs work collectively with lots of different bodies, Health Education England and other groups, who would disseminate best practice, new innovations, and then we would look to share that learning across the northeast and take it forward where we can. So I'm not sure I've 100% answered your question, but that's how some of the innovative, whether it's technological or pathway developments, would be fed into the planning process. Not sure whether colleagues have got anything further they'd want to add.
Thanks for that.
Dave?
Yeah, I think it's probably worth reflecting that some of the planning guidance will be based on cementing, if that's the right word, some of the learning from COVID. So there's lots of transformation that's taken place that's got to a point but can be taken further. So there's likely to be something there about transforming outpatients, continuing to transform access to general practice. And there's some stuff likely to be in there about increasing diagnostic activity, but also access to diagnostics that we'll need to have a look at. But that'll be about doing things in different ways as well as new technologies. So I think when we get the detail tomorrow, we can certainly go through it with the rest of the governing body in terms of what the ask is and what our approach will be locally.
Okay, thanks, Dave. David, any follow-up from those answers? No. Okay, thanks. I've got a sort of broad financial question in that we've now had the experience of almost a year of running under the sort of unusual circumstances and the financial allocations. Is there any learning in relation to how the flows of money to the commission services that we've had over this year, is there anything that we need to sort of watch out for the next financial year? Has the flow, because of the changed circumstances, been good enough to support our providers financially so that they're not at risk of having problems delivering clinical services?
So a couple of comments really. One is that the method of financial flows where we've operated as a system has definitely had some benefits in terms of making sure that the money flows quicker, faster through to our providers. And I think all parts of the ICP would recognise that. In addition to that, there are some almost bureaucratic elements that have been cut out of the system in terms of some of those financial flows. And I think providers and commissioners recognise the benefits of those. In terms of those clinical services, what the basis we've tried to work on this year is to ensure that providers have sufficient funds, and that's the method of calculation that's being worked out nationally. That's where the block contracts that I mentioned in the slides come from. So they've been calculated on the basis of a provider cost basis, and therefore that helps those providers to ensure that they've got sufficient funds to take them forward. The challenge then comes in terms of some of the transformation work, some of the new technologies, and the traditional inflation aspects that represent the NHS as we move towards new medication and new devices, and whether that's going to be reflected enough in the allocations that we get going forward. So that represents a bit of a risk until we've got some clarification on that, I think, Jim.
Okay, thank you. Anybody else? I've got one more question, but I'll give anybody else an opportunity to leap in if they want. No, this is more towards Craig probably, and I realise it's difficult because you're going to get the planning guidance tomorrow, but would you say the system is now flexible enough from a planning perspective to be able to cope with if, for example, we get a third wave of COVID, particularly in view of the concerns as to what's happening with COVID in Europe? Thanks.
I think what we can say is that we've got the right arrangements in place to work in partnership across the ICP POS so that we can respond in the best possible way. So in terms of system flexibilities, joint working, partnership working between primary, secondary and community care, then we've put ourselves in a really good position. But there's always going to be challenges when we're trying to run a full routine program of work, which includes routine general practice, an elective program in the acute trust and the routine community care that we provide alongside any surge in COVID cases. And it's like running another winter period alongside everything else that goes on. So it's always going to be challenging for the NHS as a whole, but I think we've put ourselves in the best possible position to respond to that through the way we've approached our collective response. And just the approach that we've taken, joined up with colleagues in local authorities, public health, all of our different providers coming together twice a week, more on some occasions, to actually look at what are the challenges we're facing, how can we work together, what pressures is one particular part of the system or one organisation experiencing, and then how do we look to work as a collaborative to relieve those pressures. I think it's been a really good example of what we can achieve when we all come together, and you would hope that the governance arrangements we put in place would support a continuation of that work here, whether we see a third wave or not.
Absolutely. Right. Thank you very much. Okay, so we note your financial and planning update. And move on to committee terms of reference. Jackie, over to you.
Sorry, wasn't coming off mute then.
Don't apologise, I did it.
I thought I'm not going to move my mouth before I see that line move. This is the annual review of the terms of reference. You'll notice obviously that it only includes the Audit Assurance Committee, Primary Care Committee and Remuneration Committee at this stage, because we are doing more work with the Quality Committee at a development session in the coming months, hopefully, and there may be an impact from that on the Executive Committee, but also taking into account the work that we have just done in terms of reviewing our effectiveness as a committee structure and governance structure might have some impact on the Executive Committee terms of reference as well. So that's the reason that those two committee sets of terms of reference haven't come. The three that you do have are subject to quite tight restrictions in terms of national guidance, legislation and good practice, such as the Audit Committee Handbook. The terms of reference do continue to comply with all of those. They were subject to rigorous review by NHS England as part of the merger and were confirmed as being legally compliant. So there are no suggested changes to them, although each of the committees has been given the opportunity to review them and ask if they did have any suggested changes to membership or frequency, anything like that, we have a little bit more flexibility on. So they're here really for governing body ratification.
Okay, thank you very much. So thanks for the work you've done in relation to that. Anybody want to raise any questions prior to us approving the terms of reference for the audit and assurance, the primary care commissioning and the remuneration committee? Okay, so everybody okay with that and okay to approve those terms of reference?
Yes.
Yeah, okay, great. And then we move on to the draft annual cycle of business. There's a sort of large table of various dates and things. Is there anything you want to particularly flag there, Jackie? I've got a couple of questions, nothing major.
Okay, it was really just to say that...
Jackie, sorry, Caroline, I've just spotted has got her hand up.
Sorry, it was probably a bit premature. I was just going to ask about this cycle of business, if we could include something around EDI. I met with Julie Bailey and Hannah Brooks and Jake, and we talked about doing an EDI position statement. And it would just be good if we could see that reflected, even if it's just one.
And the changes to financial and operational planning as well. But this just sets out a little bit of a guide for the year, really just to aid planning. It's not set in stone, it just gives an indicative indication. And I've had a conversation with Julie about the EDS element of it as well. So yeah, we will be including that. It's not a problem. And you'll see that in terms of the dates, there is still a little bit of clarification just need to be confirmed in terms of the receipt of the annual accounts, but Mark touched on that as part of his presentation earlier on as well in terms of finalisation of annual accounts. So it's just to receive.
So Jackie, is that the reason why the annual meeting is sort of the dates are up in the air?
Well, the annual general meeting has to take place before the end of September. That's a legal requirement, but we can't obviously have the annual general meeting until the annual report has been formally published. So it's just getting all of those ducks in a row, really. It's usually the middle of June that we would publish the annual report, but we haven't been given a date of by when it needs to be on the website and published yet.
Okay, thanks. I've got Jean with a hand up and then Caroline.
Thanks, Pos. Just some very, very small points just to add before we agree. It's actually a quality and safeguarding report that comes to each, or I'm happy to make it just a quality report if colleagues would prefer, but it needs to be quality and safeguarding. And then in November, it's got quality accounts. I think that needs to be a little bit more specific and say NHS provide their quality accounts and CCG third-party statements or something like that.
Okay, that's noted.
Just for clarity, thank you.
Thank you. Caroline?
Just for a point of clarity on the table, it says May the 26th or the 7th of June to be confirmed. That's the 9th, isn't it? Isn't it the 9th of June?
Okay, we'll get that nailed.
Yeah, just in case people take the dates off that. I think it's the 9th. That's a Wednesday.
Okay, we'll double check that and confirm. Yeah.
Okay, Jackie, I've got just one question in relation to the couple of the things that you got for the 23rd of March next year, as in terms of reference for committees and annual cycle of business. Now, considering what's planned for the CCG and ICS, should we either move it forward or possibly even delete that?
I mean, it is indicative. It's not going to be the committees for our organisation, but we may well need to have some sort of governance route of when things go up into an ITS board, and we don't know how the governance of anything's going to work as yet. So I think I'd prefer just to have a flag of terms of reference, whatever those terms of reference might be. It can easily be crossed off, but it's easier to cross something off, I think, than remember to add it in.
And should we have some form of signing off, final business to transfer over to the ICS arrangement, and should that be in the table? Dave?
Yeah, I think that they're really good questions, Pos, and I think that's why we can agree this today, but be really clear that this will have to be very, very flexible, because we're asking questions we don't know the answers to just at the moment, so we need that flexibility from everybody, really.
Okay, so we can revisit this if necessary.
Yeah.
It's indicative. It'll move every month. Yeah.
Okay, so we agree the present indicative cycle of business, and we'll tweak it if necessary in the future. Everybody okay with that? Yeah. Okay, so we come to our 10-minute break. We've been going just about an hour, so this is an opportunity. Oh, sorry, Jean, hand up. I didn't notice before we go off for 10 minutes.
Yeah, sorry, Pos. I thought I had put it up. Just quickly, 2 other points on that cycle of business, recognising what Dave's just said about indicative. There's something down there near the bottom in terms of South STHFT. I can't see where it's gone now. Yeah, under the in-committee items, STHFT confidential update. That's not actually on a cycle of business. That would be part of any confidential quality and safety update, I would suggest, unless colleagues want something different.
We'll take your advice on that, Jean.
Yeah, and then the quality accounts, sorry, the complaints annual report. Well, we do have 2. We have the next complaints pretty much performance, which is numbers and categories, and then we have the more national ones. So I think we just need to reference that as well, please. Thank you.
So if you liaise with Jackie as to what's needed for that. Yeah. Okay, and on the basis of that, we'll agree that those proposals, subject to tweakings as what you need between yourself, Jean, and Jackie. Okay, right. Thank you very much. Back at the suggested time of 3:25, so we've got slightly more than 10 minutes, folks, for nature's cause or refreshment. Vicky's here. 2 more minutes and then we'll get rolling. Vicky, I think you probably know just about everybody on. I hope you do. I'll just, if you would just introduce yourself to Nick, and Nick, if you introduce yourself to Vicky. Okay, Vicky first.
Hi, so I'm Vicky Spools. I'm Assistant HR Manager for Next HR, but I support the CCGs.
Okay, and Nick, over to you.
Hi, I'm Nick Marco. I'm the local democracy reporter based at the Hartlepool Mail. I've been sitting in on the meeting today so far.
I admire your stamina, Nick. Anyway, yeah, you'll have an opportunity to ask any question you want towards the end. Right, okay, so Vicky, over to you. Imperial College Healthcare Trust disciplinary policy, good practice and national recommendations. Over to you.
Yeah. So we're bringing this paper with the updated policy. We've done a review of the CCG's disciplinary policy, and this was following a tragic event in 2016, which resulted in a nurse taking their own life, a nurse who was employed by the Imperial College Healthcare Trust and was subject to an investigation and disciplinary procedure. Following this tragic event, there was an independent inquiry in 2019 that did conclude that, as well as procedural errors, that the nurse was treated poorly, and so much so that it had a significant impact on his mental health. So NHS Improvement established an advisory group to consider what lessons could be learned as a result of the independent inquiry, and that could be shared with all NHS organisations. So the advisory group in 2019 came up with 7 recommendations. And what we've done is we've took the CCG's disciplinary policy, reviewed it alongside the 7 recommendations, and also the Imperial College has also updated their disciplinary policy. So we've reviewed ours against the recommendations and the disciplinary policy. So in the paper, you'll see that as a result, we've now strengthened the disciplinary policy in the following areas. So the first one is adhering to best practice. So whilst our policy always said that we would adhere to ACAS guidance, we've now strengthened it to include that it is in line with the GMC and the NMC best practice on guidance on local investigations. So we've done a review of their guidance and happy to say that ours is in line with those as well. The next recommendation was applying a rigorous decision-making methodology. So we've added in the policy principles that all measures should be taken to ensure that there's complete independence and objectivity at every stage of the investigation. And we now detail that a rigorous decision-making methodology will be applied when we're determining next steps and any sanctions to be issued. It also includes that any decision would be transparent, evidence-based and fair. And in addition, we've confirmed in the policy that we'll have clear terms of reference that set out the scope of the investigation, and they will include a clear communication plan that would be shared with all parties. Ensuring people are trained and competent to carry out the role. So the policy already give a commitment that anybody who's undertaken an investigation would be suitably trained and have the necessary skills. And just so you're aware, we are in the process of rolling out management training for managers, which includes training on the disciplinary policy as well. Assigning sufficient resources, which is really important. So we now state in the policy that before commencing an investigation, that the manager who's been appointed the investigating manager must ensure that they fully support the timely and thorough completion of the procedures. It also specifies that the facts and evidence will be provided to the disciplinary panel prior to any hearing, and that they should allocate time to go through that information prior to the disciplinary hearing. Decisions relating to implementation of suspension and exclusion was already included in the policy, but again, just strengthened that any decision to suspend would not be taken by one person, except where there's immediate safety or security issues. Any decisions to suspend should be a measure of a last resort, time bound, and only applied where there is full justification to do so. We've also included that a continued suspension would have the appropriate oversight of a director level. Very important, the next bit about the safeguarding people's health and well-being. So the policy now has some information in there about any party that's involved in the investigation, whether it's a witness or somebody who's had allegations made against them, that we do support their mental health and well-being, and it's paramount to the investigation, and including things like occupational health. And it is also in line with the people plan as well, that as part of this we support the mental health and well-being of any individuals. Board level oversight. So we do, on a quarterly basis, we do provide information on any employee relations cases. So we've strengthened this in the policy that on a regular basis, we'll provide any information on statistical information, on any ongoing disciplinary cases, including any workforce information. I have to say that thankfully we don't have a lot of disciplinaries within the CCGs, but obviously we have had this policy, which is robust, but we've been able to strengthen it in line with those 7 recommendations. So we reviewed it with all the CCG HR links and trade union representatives, and the version that you've been sent, we're now confident that it includes the recommendations from the task group that was set up to look into this.
Okay, thanks, Vicky. Andy, you got your hand up.
I think it's the tragedy of where this was born from, but it takes us to a great place, and I'm pleased to see it. I think it's a very complete piece of work. Couple of minor observations. Sometimes when you don't practice with something, that's when it can go wrong. So I think that's an observation we need to understand, that we're lucky we don't have them very often, but when we do have them, that's more reason to have a greater oversight, because it's not something we're using all the time. I was interested in the scheme of delegation. So when you get to dismissal and that dismissal's appeal, there's no sort of independence to the people hearing the appeal. Quite often in those sorts of examples where the future of their employment is at its last stage, often they use independent members, such as lay members, or I'm just wondering whether there's a reason why we don't consider that, because again, that would add to the transparency of the decisions if they ultimately do get dismissed. I just wondered what that was, because that is also an ACAS guidance as well. But a very, very good report.
Yes.
Okay, Vicky?
Yeah, so just, sorry, I'm just getting the scheme of delegation up. So the independences that we wouldn't have anybody on the appeal panel who'd been part of any dismissal. So that would be the independent. We would have different people on any appeal panel who've been involved before. So as it says, appeal against dismissal would be the chief officer or the chief operating officer plus another manager.
Okay, thanks. David?
Thank you. Yes, I certainly welcome this from the point of view of safeguarding people's health and well-being. This report came on the basis of one suicide. I know nationally between 2005 and 2013, something like 28 doctors who committed suicide who were under investigation by the General Medical Council. And these investigations do have had a great toll on healthcare staff over the years, particularly of doctors. And I think support is so important, and it's great that there is this reference to both the People website and occupational health. I mean, when I worked as a medical director, I used to do my very best to get people to bring either union rep or some other support with them to meetings, so there was somebody with them initially, and then point them as well to occupational health as to some other support. For example, British Medical Association have a support line for doctors, and if people are registered with GPs can give support. And I think it's so important, and sometimes people will go to support which is away from either the trust or the CCG. There's something that they see as a bit more independent, and I think this sort of support is absolutely vital to keep people secure. So it's great to have that in the policy. Some policies do state that people mustn't bring family members with them to sort of any investigatory meetings. I didn't see that specifically said in this, but it does refer to trade union or work colleagues. So I think that is implied by it, but certainly welcome this and the support that it gives to staff should this type of situation arise. So thank you for it.
Thanks, David. Jean and then Karen.
Thanks, Pos. I think David makes a really helpful point there, and I think depending on the nature of the incident as well, because this is obviously by definition, if it's a policy, it's a blanket policy, but particularly in the past when we've been faced with challenges like this, sometimes some of these investigations do actually involve the police as well. So there is a whole, excuse me, additional element there of access to support agencies or functions as well. But I think what's key in this policy, which as I understand it, Vicky, where you're going with, is it's about the being specifics that we need to consider that. And there are a number of ways to actually include that and access that. We do have to remember, of course, that you can lead a horse to water. But I think it's in terms of it's safeguarding as well as caring whilst the process is ongoing, isn't it?
Okay.
Thank you.
Yeah.
Karen?
Thanks for that. Very thorough piece of work, which I, like everyone else, I do welcome. I was just interested in the terms of reference for the investigation, because I've been involved in a lot of these over the years, and in some cases you start off investigating one thing, and it's as you pull the thread, all of a sudden you're moving into other areas. I just wondered how that is dealt with if you have rigorous terms of reference at the start of it.
Okay, Vicky.
So the terms of reference does, there's a paragraph in there that we would initially set out the allegations at the beginning of the investigation, but it does allow that if additional information does come to light throughout the investigation, that it may be that is also then forms part of the allegations. But if we were going to do that, we would of course have the discussion with the individual and the trade union rep, but we do allow for that in the terms of reference template.
Okay, thanks. Can I just check that this discharges the recommendation in relation to board level oversight? Does this form any part of an annual report on staffing matters that comes to governing body? Dave?
Yeah, thanks, Paz. One of the things that we do get is a quarterly report from next colleagues in HR that includes this information. Now, the quarterly stuff we take to exec, but when we get the Q4, which is kind of the end of year report, if you like, that will come to governing body because it'll just wrap all of that up. So the reporting that's mentioned there is probably picked up already by that approach.
That's great. I was just wanting to formally check that. So yeah. You're signing it off. Great stuff. Okay. Well, thanks, Vicky. I think everybody reckons that's been a really useful and comprehensive bit of work, and that's put us in a good position. Thank you very much.
Thank you, everybody.
So we received the report and note the changes to the policy. Thank you very much. Lovely. Okay, over to you, Dave, now for a verbal update on the integrated care system changes proposed across England, stroke, in brackets, ICS. So when everybody refers to ICSs, Nick, that's what it is.
Yeah. Okay. Thank you, Paz. And I'll start with an apology. I would have hoped to have brought a written report to this, but as we've rehearsed already, some of the guidance for this is due to come out tomorrow, which is completely out with our hands because that's linked to NHS England's board meeting. We've touched on this a couple of times already in the meeting, but probably just to give an up-to-date position about where we are. Since we met last formally, the government has produced a white paper that will go through Parliament looking at moves towards integrated care systems becoming statutory organisations within the NHS. And we're expecting some planning guidance to come as an annex tomorrow in terms of some of the detail for this and some of the timelines. But as the white paper outlines, as of April this year, i.e. the month we're about to move into, all NHS organisations were required to be part of integrated care systems, which is the ICS bit. So that is the case. We've got integrated care systems. We're part of the North Cumbria North East integrated care system. However, it's not a statutory body, it's a partnership at the moment, and the white paper is suggesting it becomes a formal statutory body. The white paper suggests that from April 2022, so that's a year beyond where we are now, a number of things will be in place. One, there'd be provider collaboratives, which would include all foundation trusts and trusts across the country. Two, that there would be commissioning functions from CCGs and potentially from NHS England would transfer into a statutory body, the integrated care system, and that would all be subject to legislation. The legislation is lined up so that, as normally the white paper will become a bill, would go before Parliament to become an act once it's given royal assent. The timelines look as though that royal assent would be given around January, but obviously that depends on anything else that's happening nationally. And that creates a little bit of a problem in terms of, while we might know what the overall direction of travel is, until that becomes legislation, so it can't be enacted. So there's lots of stuff about to be happening in terms of guidance. There's certainly a people framework that's due out next month. There's also some more information on what some of the system requirements might be. And when we were talking earlier about the planning guidance, there's an ask in the planning guidance that ICSs produce a plan for how they will operate going forward. So there's lots of things still up in the air, lots of things to be decided. The key bit for us as an organisation is we will need to work through this in terms of how we can transfer functions from the CCG into the new statutory body. And there's a commitment in there nationally for all staff who are below board level, and that's to be determined what that means below board level, to be transferred into the ICS going forward. There's very much so a commitment from all of us involved in this to get the clarity as quickly as possible for staff so they understand exactly what that means, so we can actually start to plan positively moving forward. So there's probably not much more to say at this point in time. There might be, if we'd have this meeting tomorrow, unfortunately, but this will be an ongoing conversation that we'll be having with the governing body and with partners about how we take this forward. So probably not much more I can say other than I'm happy to take any questions or comments, bearing in mind there might be some that I just can't answer because we just don't know at this point in time.
Dave, do you want to pick up any of the points that were raised in relation to the councillor members' report earlier? General practice.
I can do, yeah. I think all of the points that were really well made, the points that are being made by other practices and other CCGs as well, and there will need to be a process to see how we take this forward. But what little we know at this point of the detail of what an ICS looks like, it does commit to having input from general practice. How that happens is very much up to debate, and obviously it won't involve every single practice sat around the table. It does allude to PCNs, primary care networks, having input into this. We need to work through that locally as well as nationally to see how that works over the next couple of months. But all the points that are being made are being fed into the conversation. There's obviously going to be quite a bit of work to do over the next few months as we move into what could be a shadow form at some point in the next financial year to make sure that we get a system that actually works and does everything that it needs to do, so that as functions are transferred, they're transferred safely and they have a home and a place to go to.
Okay, thanks. Anybody else got any questions or comments in relation to Dave's update? No, once again, it's sort of a bad timing from a point of view of our meeting. We'll be able to discuss with more concrete information, I suppose, in 2 months' time when we've got our next formal governing body meeting. And we're regularly updating all the staff within the CCG with what information we have. And also, as I pointed out in my chair's report, that we're preparing for a process of engaging with our member practices. But as Dave's just said, we've got to wait to see what comes out of particularly the information coming up in the next few days. Okay, so we'll receive that report, note it, and we'll move on unless anybody's got a hand. No hands up. Okay, so we move on to the finance report for the 10 months ended the end of January just gone. Over to you, Mark.
Okay, thank you. So as Pos says, this is the report to the end of January for the first 10 months whilst we're in the temporary financial regime. At the moment, the CCG is forecasting a surplus of around about 4.5 million for the year, which is an improvement from last month's position. That equates to around about 0.3% of our turnover. The planning for the start of this financial year, you may recall, assumed a level of drawdown, so the CCG requesting support for its financial plan. This level of surplus would reinstate that. And although we don't know the final rules around drawdown and surpluses and how they'll be handled, I think it's a positive message for the CCG. We've tweaked the report slightly, or the presentation of it this month, to draw out the anticipated funding and make it quite explicit that that surplus is on the basis of anticipated funding. It is low risk, and I'm pleased to say that at the point of writing, we've now received funding up until months 9 and 10. So what we now have is all funding in respect of service developments that had been expected, so 100% of that has been received. We've also received funding for the hospital discharge programme costs, and we've received those for month 9 and 10 too. Hot off the press, we've now had an allocation for month 11 and 12 based on an estimated level. So the hospital discharge, which is outside of the fixed finance regime we have, is effectively covered for the remainder of this financial year, which again is positive. The main areas of movement in our forecast were around two areas really. One for continuing healthcare, where we've seen lower growth in patient volumes and lower growth in costs than we previously expected, and also lower costs in respect of the additional roles reimbursement scheme in primary care, where some of the national forecasting models effectively overstated some of those actual costs when they came through. With the current financial regime, we have a role as a CCG in supporting all of our NHS partners across the ICP. Now, at the moment, there are some uncertainties as we approach the end of the financial year around accounting treatment for a couple of areas in particular. One to do with non-NHS income, and that reflects or impacts upon providers in particular. So if you think of areas such as catering income or car parking income, that has definitely been impacted by the pandemic. So that's one area of uncertainty for providers. And another is in respect of annual leave or untaken annual leave in particular, where those days have been unable to be taken because of service pressures. So both of those are awaiting clarity from NHS England, NHS Improvement at this time. Having said that, the CCGs discussed the current position across the ICP with partners and agreed the further deployment of funding to support some of the financial challenges that South Tees are facing, and that amounts to 6.452 million. And around the table as part of those discussions are the other FT colleagues covering both acute and mental health services. So that fits with the requirements of our ICP partner arrangements. We'll continue to monitor that ICP position because even this morning we were receiving and signing off additional allocations that flow through the CCG to some of those organisations. So we're running right up to the wire this year in terms of some of those financial flows. So we'll keep those under review, working with our partners in the NHS and the local authority, just in terms of delivering the forecast surplus that we've mentioned at 4.5 million. So that's where we are. We're not expecting any significant change in that position for month 11 or month 12 for this year, but I'm happy to take any questions on that.
Okay, open to anybody for questions. While people are thinking, am I correct in interpreting what you said in relation to the surplus, that we potentially started in a position where we would have had no buffer whatsoever at the beginning of the financial year, and now at the end we have a teensy little bit of buffer available, particularly to be able to cover off things like you were discussing in where there's uncertainty in relation to potential spend?
Very good way of putting it, actually. So at the start of the year, we drew down everything that we could in order to try to balance the plan position for this year. As we get to the end of this year, we've got the opportunity to put some of that buffer back. We don't know the rules yet around carry forwards and surpluses and things, but what it does mean is that we're in a very similar position to that which we were at the end of last financial year. So that's good news, I think.
Yeah. Okay. Well, thank you very much, Mark. That's a financial reporter could pretty clearly understand. Right. Any last opportunity for questions from anybody? No. Thank you very much, Mark. So we Consider the reported financial position, note the financial forecast, and note the funding will be kept under review to address potential pressures within the rest of the financial year. Okay, thank you, Mark. And now moving over to Jean for quality and safeguarding report for March.
Right, thank you very much, Pause. So on the assumption that everybody's read it, and to save some time, I just wanted to bring a couple of things to your attention. So under South Tees, we've talked at 1.1 about never events. That has now increased since this report was written. There have been 4 never events reported this year to date. So it takes the total, so they're talking there at 16 since the beginning of 19, but it's actually 22 since April 2018, which is the beginning of when we started to have discussions around never events. Still under similar headings, with the exception of patient identification as well. Other things to bring to your attention is obviously the mortality. The SASTs being outside of expected limits. This is not an exact, it never was an exact science, because we've always talked about mortality metrics and they're indicative. Obviously, with our current COVID pandemic and the very sad number of deaths that everybody's dealing with, statistician colleagues are working hard to try and make sense of all the mortality metrics, but for now we still use them as much as we possibly can for an indicator. For North Tees on 2.1, we're talking there about paediatric services. That work is ongoing in terms of how the Trust looks at its services, how the CCG can work collaboratively to support that. And then the non-invasive ventilation incidents. We've reported it here, but I think the context of this needs to be very mindful that this is a transparent organisation in terms of its reporting culture. Their ability to recognise and report and then do something about it is to be viewed in a positive fashion. They have done some recent deep dive work on other incidents elsewhere that the CCG has contributed to and been integral to, which has resulted in some really good learning. They're going to apply that learning both in terms of the approach and as well as the investigation to this work with the non-invasive incidents and also the deteriorating patient work. So we expect the results of that to be fed through our CCG Quality Committee to be shared more widely across the ICP when that committee is resumes. So that will be helpful both for the Trust, but also the learning from the Trust disseminated more widely. Under TUV, we've referenced the CQC unannounced inspection. We do anticipate that that report will be published later on this week. And we're conscious, we're aware, and we've been kept very closely informed about a lot of the improvement work that's going on in the Trust, both in terms of work from colleagues there, but also additionality from local colleagues who are supporting that as well. So we'll await the report and take it from there. And then that's largely really what I wanted to specifically focus on, but happy as always to take any questions.
Okay. Any questions from anybody? Can I just sort of double check, so probably from Andy as chair of Quality Committee, that the CCG's process is to monitor and follow up quality and safety matters are being robustly deployed and monitored, particularly via the work that your committee is doing.
Yeah. Obviously, we've stood the committee down because of the pressures of the people who are involved in it, but that doesn't mean we're not keeping an eye on it. We are reporting through to the executive, and that's in a formal way. So the business continues to be monitored in terms of the quality. that's being fed to the executive as the lead on that, whilst the quality committee stood down. But it is our intention to get quality back onto the fuller committee as soon as we can.
Right, lovely. Okay, thank you very much. Anybody else? Any questions or comments, Jean?
Yeah, Pos, if I just may, for the record, we are still in a level 4 EPRR incident in terms of the pandemic. So in that regard, we are under central instruction, and it's NHS England who has issued a publicly available letter in terms of it's referenced as reducing the burden. So we look at what we do and how we do it, whilst not that we would ever wish to be, but with taking any onerous burden out. So as Andy's saying, we're still doing all the quality monitoring and surveillance that we would do anyway, with or without concerns, but we're just mindful that we don't necessarily meet in the traditional sense. So the work and the assurance derived from that is still equally robust. Thank you.
Lovely. Thank you, Jean. Yep. Anybody else? Any questions or comments or observations? No? Okay. So we note and receive the quality and safeguarding report, and we note the fact that it's being delivered while there's specific guidance in the form of the processes that we've got in place in the CCG due to the COVID pressures at present. Okay, thank you very much. And now over to Craig for the performance and recovery update.
Thanks, the report today is in 3 parts, bit of an update around where we are with COVID, operational performance, and then the appendices, which is the broader performance report. And I'll predominantly talk through the first 2 and then take any questions on the third, if that's okay. Yep. So in terms of the COVID-19 update, we'll start with infection rates. The information in front of you was right at the point that the information was pulled together, so it dates back to the 24th of February, just the nature of the process for producing papers for the governing body. The positions actually moved on considerably, so you can see that the T's rate per 100,000 population was up at 135. The latest available position suggests that the rate's now down at 85. We've seen a continued reduction in the number of infections in the community over the last few weeks. There were a couple of wobbles, if you like, when the children went back to school, and a couple of local increases, but the general trend has continued to be downward, and that's replicated right across the Tees Valley. And in fact, Middlesbrough's seen significant reductions. So bottom left-hand corner of the slide, the top line, the black line is Middlesbrough, and you can see that the rates were the highest in the Tees Valley, and they've now actually dropped down considerably to around 62 per 100,000. So that's a real positive sign of where things have been heading. So if we can move forward to the next slide in the pack, that was the daily vaccinations data. Now, with the vaccinations, the pace of change is considerable, and the number of vaccines that have been administered on a day-by-day basis is considerable as well. So again, the information changes quite quickly. And again, this position reported in the slides relates to the 27th of February. So again, things have moved on. The information is pulled from the NHS England COVID statistics website, so it's routinely available to the public. Again, the latest position is somewhat different, and you can see that the T's position was slightly behind the national average in terms of the number of vaccines that had been administered. I can confirm that based on the latest published information, the cohort 65 to 69 were now at 90% coverage, 70 to 74, 99.5%, and 75 to 90, 100% of those people expected to be in that age bracket have been covered. Now, that doesn't mean everybody in that age group has, but in terms of the numbers that were forecast based on ONS numbers, the vast majority, pretty much everybody in that cohort has been vaccinated, and an 80 pluses is at 94.5. So what that shows is over the last month there's been significant progress with the older age group at least having 1 dose. So they're all single doses. And the latest cumulative total for the Tees Valley, as published through the NHS England website, is 262,000 doses. So I think that's great progress from where the data was originally pulled from. Clearly, day by day, the numbers are going up, and this information is already out of date that I've just quoted because it's a couple of days old already. Okay, so in terms of moving forward through the pack, our current activity level, so this is a bit of the operational performance now, looking at where we are in terms of what we expected to be doing routinely without COVID playing a part. We're not actually hitting the levels of activity that we'd anticipated across the board, and that is predominantly down to availability of capacity and hospital beds within the hospital settings. So our day cases and our inpatients are below where we would want them to be across a number of the sites. There are some positives in there. So South East Hospitals Foundation Trust actually doing slightly more day cases up to the end of December than they'd planned. Over at Carrickdrum and Darlington Foundation Trust, they've been able to do more inpatients, so more of your major surgery than they'd originally planned. But the other providers and other points of delivery are somewhat behind. One area where we tend to do, or we have historically done better during the COVID period, is around the outpatients, and that's supported by the shift from face-to-face to non-face-to-face. But again, that is subject to ups and downs, and certainly outpatient first attendances had dropped off somewhat in the run-up to the Christmas period, and that continued through January as well. So in terms of some of the key performance issues that we're working to address at the moment, we've got continued pressures around our long waiting times. So over 40 plus week waiters and over 52-week waiters. And whilst the numbers are still high, we're not seeing the growth that we had seen earlier on in the pandemic. So as the elective program's starting to come back online, we're starting to consume some of our own smoke in terms of each month, the numbers being added to the list. But there's still a considerable task ahead for all of our trusts to work through in terms of reducing the ICP level waiting times back to anything like they were pre-COVID. And in terms of cancer performance, again, the position has shown improvement over recent weeks and months, but we do still have long waiters. We've got all of the safety nets and measures in place that we would expect to have in place with the trust, with weekly reviews, and the fallback position of the 104-day backstop, so reviewing all those patients who come towards the 104-day point. They're all reviewed at the 80-plus day point. So that work's continuing, and in spite of the reducing the burden letter, we're continuing to have good discussions with all three providers around the performance issues that they're facing and how we're going to overcome those as we move forward. Within the slide deck, we've listed some of the key performance activities and mitigations that we're working through. I wasn't going to run through those in any detail, but they're there for information. And that's predominantly it in terms of the update. The appendices does detail the performance against each of the constitutional standards and KPIs and key performance indicators that the CCG and the ICP is held to account for. Be more than happy to answer any questions on those, but I wasn't going to run through those in any detail at this time, boss, if that's okay.
No, that's great, Craig. Thank you very much. Any questions, observations, queries? Once again, while people think, you've got it on the slide deck that patients who've been waiting a long period of time have got very regular reviews, but do you want to sort of just touch on that in a little bit more detail we'll need to be sure that that's a robust process, that patients really are reviewed for potential coming to harm?
Yeah, so all long waiters are reviewed by a consultant POS in terms of their record and any diagnostics or outpatient appointments that have taken place. So anybody who's at risk of further harm would be seen and expedited, brought forward. So that's happened with anybody who's a long waiter in all of the trusts. And actually, there's been a regional approach to that in terms of expectations around what that review would entail and how quickly that should be undertaken across all the trusts in our region, across the integrated care system, the ICS.
Yeah. Okay. Thank you very much. Joe Bushnell.
Thanks, Craig. I found that report really user-friendly. But so how, I appreciate it might be an enormous burden, but do the long waiters, are those patients, do they get any regular communication from the trusts to explain what's going on, or is it at certain thresholds? What happens?
That's a good question, Joe. We've not had routine comms with the patients, so it's not like there's a weekly or monthly update going out to them. What we've asked is that any interaction that takes place with a patient, there's a conversation and clarity provided around the long waits and the fact that patients aren't being seen within the 18-week wait time that traditionally we would have hoped there would be. So again, that's probably something further that we need to consider as we move through the recovery phase. Our expectation is that as part of the planning guidance, there'll be some requirements around communications with patients and setting some new expectations around how long people should wait or should expect to wait for treatment. And clearly, we've been working with the FTs, the Foundation Trusts, and the independent sector locally to look at bringing as many patients forward as we can and maximising the use of that independent sector capacity, so that anybody who's waiting with a complex condition or anything that would be a priority treatment would be brought forward wherever possible. But I think that the point you make about patient expectations is a really good one, and we need to bring that right forward, right to the start of the pathway as well, so that when GPs are referring in, there's a good conversation around what patients should expect, that we can provide GPs with clarity around how long it will be before somebody might be seen in outpatients, how long it might be before their diagnostics take place, and then ultimately what might happen in terms of any inpatient episode that is required. And also keeping some flexibility in the system around conversations with patients around where their surgery might take place if it is required, because what we'll be looking to do is work across the Integrated Care Partnership, the Tees Valley ICP, to make sure that those patients with the greatest need are seen first, and that might not always be at the hospital that you've initially been referred into. It might be a neighbouring hospital or an independent sector provider, and wherever possible we'd like to support patients move into other facilities if it supports them getting treated quicker.
Thanks, Craig. I'm going to bring Janet in first, ahead of you, Mark, because I suspect Janet's got something in relation to an answer to Joe's question. Am I right there, Janet?
Well, partially. Certainly when we've been looking at earlier phases of recovery during the COVID pandemic journey, we were very keen to emphasise the need for clinical prioritisation, such that those patients who had the greatest need were the ones that had the greatest contact soonest, to make sure that obviously that it was appropriately prioritised in that way. But following on from that, I would entirely agree with Craig that we'll be working very closely with our secondary care colleagues to make sure that in primary care we are able to appropriately discuss with patients at the point of referral what they are likely to expect to have happen to them, and make sure that they know if they deteriorate, how they get back in touch with you. And for those patients who are currently on the waiting list and who will be waiting a lot longer than they were anticipating to have waited, the trust know what communication is expected of them, and that the GP is aware of what is happening with their patients that are on the waiting list, to make sure that where possible we can be as open and honest with patients as we need to be, because it's quite right that patients are clear what the expectations are, but also what they need to do as and when or if they deteriorated when they are waiting on a pathway.
Okay.
Would it be worth? Sorry.
No, Joe. Yeah.
Is it worth any sort of comms exercise to try to address expectations? I hesitate to bring sort of personal examples to the governing body, but I speak to people regularly who feel a bit lost and abandoned, even though they're trying to be very understanding, but they just don't know. Am I still on a list? Am I not on a list? Do I have to be re-referred? Do I need to keep pestering my GP, but I don't want to pester my GP? I don't know if we can address that at all with
Craig had his hand up before you, Janet, and then you, Janet.
I think it's a really valid point that Joe raises. It's something that we have been discussing in our COVID planning group. Obviously, the group shifted thinking from responding to the latest phase of the pandemic to recovery now. And I think one of the key messages that came out over the last week or so is around comms saturation and the number of communications we're putting out around when you should go to your GP, what kind of information you should be receiving, how you should access services, and it's just trying to get the balance right, Joe. So I think there is something about getting the right comms out there to people who are on waiting lists, but it's doing it in a targeted way maybe, and perhaps working with the acute trust to look at, you know, those 40+ week waiters. There's a significant number of them, potentially around 12,000 for the Tees Valley. Do we need to do something with that group in particular, so that they're aware of what's happening, that they're not putting pressure on other parts of the system by chasing up their GP or contacting the hospital, but they're still informed about the care that they should expect to receive? So I think that's definitely something we would like to pick up. Again, I'm expecting there to be something in the planning guidance around how we communicate with long waiters moving forward, what the expectations are on how long they will wait, and how quickly we can get them tracked. So it's definitely something we need to pick up with comms colleagues, and something we'll be looking at over the next week or two.
Okay, thanks, Craig. Janet, unless there's something pressing, I'll move on to Mark. Yep, okay, Mark.
Thanks, Pos. Yeah, just on in terms of the community rates that Craig referred to, just to bring people's attention to the fact that we're now doing full local contact tracing in Middlesbrough and have been doing since the 1st of March, one of 7 pilots across the country at that time. I think Hartlepool have either started or will be starting shortly, and that local contact tracing means that we can have a proper dialogue with the people that have tested positive to understand what their support needs might be, identify what financial support they might need to isolate, what other support they might need to isolate, whether they've got any welfare needs over and above that, connect them into VCS organisations and so on and so on. It's what we've been pushing for since around about September time, I think. Now, having done that, the rates in Middlesbrough, the drop in the rates in Middlesbrough coincide with us doing local contact tracing. I think it's a bit of a stretch to say it's because of it, but it happens at the same time, and I think it certainly makes me feel more positive that we're doing more than we were before, because before we were contacting people in addition to the National Test and Trace Service, so people were getting thoroughly cheesed off with multiple contacts, but we were trying to kind of, in effect, we were duplicating really, but now we're the only ones contacting, and our contact rates are 94% completion rates. The national system is much better than it was and is now 85, 86%. But I think the quality of our interactions with people that we're contacting is much better. So that'll be rolling out into Raker and Cleveland imminently, and I think other areas of the Tees Valley are looking to implement that as well. So hopefully that will help us keep the rates low.
Lovely, thanks, Mark. James, you had your hand up? No, okay, that's not. Okay, so thank you very much. Very useful report. It's particularly gratifying that the people at very highest risk, namely the very, very aged, are projected to be at 100% coverage with the vaccine, which is absolutely superb news. Okay, lovely. So we received that. And now we move on to the governance assurance and risk report to Jackie.
Okay, thank you, Chair.
Oh, sorry, Jackie, I've just spotted Jean had her hand up. Is there anything there?
Sorry, it was just a very positive comment I wanted to make, really, to share with colleagues around about, because particularly when you referenced some of the vulnerable groups, the almost universal patient feedback, and this speaks to some of the things that Michelle talks about, but also what we always think about all the time. The patient feedback about the vaccination programme has been outstanding. And although the COVID restrictions and the way it's had to be done and the way it's had to be organised, so the vaccination and the testing, just to bring it all together, each patient you speak to still feels like they've been treated as an individual. So I think in terms of patient experience and recognising that, it's just worthy of us referencing that here, because we do think about our patients all the time in what we do, but this is the feedback that we're getting from them as well. They're very impressed, and also that they feel very cared for. Just a quick comment, thank you.
Well, absolutely, I think it's worth sort of formally noting that and thanking everybody involved again. Yeah. Okay, sorry about that, Jackie. I didn't know the spot the hand earlier. So anyway, back over to you, Jackie.
Okay, no problem, pals. This is the regular governance report. I won't go through it all in detail. If I may just draw out a few points in terms of risks. The risk profile of the organisation has changed ever so slightly with the downgrading of the likelihood of the financial risk, and that's identified there at 2A within the report. Mark's obviously gone into the detail about the financial position of the CCG, which is looking positive. So that's why that has been reduced at the moment. There are currently 23 risks on the risk register, and 12 of which feature on the assurance framework as high-level risks, which are a residual rating of over 12. The Executive Committee, as you know, has responsibility for the oversight of all risks on the risk register, where the governing body only tend to receive the high-level ones. So the Executive Committee looked at the full risk register on the 8th of March, and were satisfied with the controls and assurances that were in place. There were a few risks that still needed to be updated at that point, just due to annual leave and other absences, but I'm sure they'll be done shortly. We'll be doing further work in the next few weeks as the corporate objectives are reviewed and come back to the governing body development session to discuss. Then we'll pick up the work that we talked about in terms of risk appetite and looking at each of those objectives and seeing if there are any other risks that we need to be taking account of in terms of the way we move forward over the coming year. Moving on to section 3, review of effectiveness. The governing body, in line with good governance practice, has carried out a survey monkey of governing body and committee members to see whether there are any opportunities to review the way that we work. We've had some suggestions, which is excellent, and I'll be working on those with various people just to take forward so that we can ensure that everybody is looking at the right things, the correct level of focus is being able to be made, and also to make sure that our systems behaviour and reporting allows for good levels of discussion and debate, as well as information giving, so that we're getting information out to the right people at the right time, at the right level, and we're not focusing too much on giving the information, but being able to actually discuss things. We talked about terms of reference earlier on in the meeting. Declarations of interest, just a year-end update really. We successfully achieved almost 100% training. There was only one member of our clinical lead staff that was unable to do their mandatory training within the time frame, but she did manage to do it a couple of days later. So effectively we were almost 100%. And just to note that that individual isn't actually a decision maker, so there was no concerns raised there. At the time of writing, we didn't have our audit report rating. That has since come through, and we received a substantial rating, which is a really good reflection on the work that's being done by everybody across the organisation to ensure our transparency. And there were 2 areas of best practice identified and no areas of lapses in control identified. So thank you for everybody for the work you do to keep that level of transparency. Information governance, we would normally be submitting our toolkit at the end of this month, and that is a self-assessment against how we keep patient and staff information safe, all other areas of good information governance, as well as the integrity of our cybersecurity systems, working with our commission and support colleagues who provide those services. This year's been different. The toolkit submission date isn't until the end of June because of COVID, but we were required to submit a baseline assessment at the end of February. At the time of writing, that was at 46% complete. That has now increased to over 60% complete. And there are about 90 assertions associated with the toolkit, and many of those have got sub-assertions too. So it's no mean feat. So there's a lot of people involved in that, and the CSU do a significant amount of work to support us with that. Those were the key areas that I wanted to highlight, and I'm more than happy to take any questions.
So Mark, Pickering, you got a...
Thank you. Not a question, just a comment really. So just to demonstrate how this report links to the two financial reports we've had earlier in the meeting, the risk rating we've reduced in here links to the in-year position of the CCG, and we've recognised the forecast surplus position. So I think that's exactly right. Because of the uncertainty around future years' financial allocations, we'll review the risk rating as we move into 21-22 as we get further information later this week and next week. So it's just that clarity about how our risk rating is live in effect. So we've reduced it on the basis of what we know now. We'll continue to review it as we move forward into 21-22.
Thanks, Mark. Jackie, I've got one question in relation to the IG matters. And has the information governance toolkit and how we assess ourselves had to change as a result of the, effectively we're all working online from home? Has that had any impact on what we need to do?
The toolkit itself hasn't changed as a result of that, but some of the controls that we've put in place have. So we regularly remind staff about good information governance practice in terms of where you're having meetings and things like that and being overheard. I don't think my dog counts for that, but so we remind staff about that, because you're absolutely right, Paul. Sometimes it can be easier to forget things when you feel safe in the comfort of your own home. So we do try to regularly remind staff, and we've updated, when we're updating policies and standard operating procedures and things like that, we have the Information Governance Staff Handbook, for example, we've updated it to reflect the more agile working practices, so that the continue moving forward, so that it takes that into account.
Okay, anybody else? Any last opportunity for questions, comments? No, thank you very much. So we receive and note the updates in the report. Thank you very much. And back to you again for the merger benefits realisation plan.
Okay, thank you. Thank you. The merger seems such an awfully long time ago now. I was looking forward to a whole new world yet again. We are nevertheless still required as part of the merger process to submit an end-of-year report to NHS England in terms of measuring the benefits that we identified at the outset as part of the merger application. There is no set format for that, and we've not received any guidance about how that should be done. What we have done, therefore, to ensure that we continue with the audit trail and we can see how things have moved across, is use the same format in terms of the benefits that we identified and the benefits that we indicated to the public and other stakeholders at the time. And we've used those as our framework, really, for the report. It is high level, not least because some of those areas are actually quite difficult to measure, given that the year we've had. We can't put reduction in travel costs or our increase in digital technology down to the success of the merger, because obviously things have overtaken us. What we have been able to do, though, is work very agilely, be very fleet of foot. We've got an excellent network arrangement, and in terms of working together with local authorities and other stakeholders to respond to the challenges of the merger, certainly the challenges of COVID and the pandemic, certainly the merger and being one organisation has inevitably helped us with that. So we've tried to express that as we submit this to NHS England. The Executive Committee did review this a couple of weeks ago, but obviously we wanted to bring it to the governing body as well for information and any comments that you had to reflect on.
Yep, thank you very much. I like the layout of the format, is sort of the answers in green immediately after the question. Caroline.
Just a brief comment. It was good to see this, actually, to see that some of the, obviously, the benefits of the mergers were realised, and it was really set out well. So it was a good report to see, and I think it's important that it is done and that we do feedback. Yeah.
Yep, lovely. Okay, last opportunity for other questions and comments before we move on. So that report is noted prior to the submission. So now we come to the information bits. So reports for information from the committee chairs, audit and assurance executive and primary care. Anything that committee chairs want to flag? No. Okay. Items to note in relation to minutes received, various committees, and other minutes received: Northern CCG Joint Committee, Hartlepool Health and Wellbeing Board, Stockton Health and Wellbeing Board. Anything to flag from those? No. Okay. Any other business? We haven't had any other business notified. So, Nick Marco, this is your opportunity. Is there any question that you wish to raise, particularly if you'd raised any formally before we started? Over to you.
You'll probably be thankful to hear there aren't any, actually. I joined along really just for a bit of an update on how everything's going. And I think certainly the last couple of reports, sort of the performance reports on COVID and everything's more than covered everything. So, yeah, nothing.
Just as a feedback, did we manage to avoid abbreviations or explain abbreviations and NHS jargon as we went along sufficiently for you to be able to gather what we're talking about easily?
Yeah, pretty much. I think there's the one that you pointed out when it was said, but other than that, yeah, everything was easy to pick up. Going through some of the reports as well, even obviously some very complex issues, they were still quite easy to grasp and sort of get the gist of what was being mentioned. So yeah, it was all positive from my view.
All right, well, thank you very much for your feedback. So in relation to risk register, I think we've sort of fairly thoroughly covered all the stuff that in relation to risk register already, having had the risk register mentioned in the report. Is there anything that anybody wants to flag or highlight that we may need to otherwise consider for our risk registers? No, no. Okay, so leave things be. Thank you very much for your time, folks. I hope you feel that we've had enough time for discussion and consideration. I realize in our feedback that some of our agendas can be very long and can seem a bit pressured in relation to discussion time, but I think we've managed to sort of have a good enough balance between time of completion. The time assigned on the agenda has worked out really well. So thank you very much for your attendance, and I'll wrap the meeting up. I think if I